And that's one of the worst ways to start a talk ever. Virtually, you can start a talk on mute, or the other end can have you switched off, or you can have the camera switched down, staring at your own lap or something, and it's an appalling beginning to your presenting. Actually, this first slide is pretty dodgy as well, but let's talk about how you do presentations. And I'd like to bring back or introduce you to a concept called P cubed. When we are giving a presentation to people, we want to inspire them often. We want to transmit some degree of information, and we frequently want them to go away feeling better than they started off. Not always, but frequently we do. And this idea of P cubed captures some of the things that you need to think about to put that together. You need to think about what is the story you're telling. How are you going to get this message across? How does it start? What's the middle of it? What's the end of it? We'll go into it in a bit more detail. You need to think about story, but you also need to think about what's going to help you tell that story, called your supportive media. And you might think about this as largely being your slides, but it's only largely your slides, not entirely your slides. And then the third thing after the story and the supportive media is how you deliver that message, the way that you do the presentation, the actual delivery that's going on. And so the first thing that we think about is the story. What is it that I'm trying to tell you in this presentation? Where am I starting? Where's the clutch points within it? Where do I want to exit at the end? And if you think about story, you've got sort of the idea of the 7 frames that all stories sit into, and they may be tragedy or comedy or a quest or beating the monster or rags to riches. There may be romances in there, and maybe tragedies that are occurring. What is the story that you're trying to tell when you're giving your presentation about the role of XP23 mutagen agents in the methylation of twirly methyl twirls, or whatever it is you're doing, or how to stop kids puking before they come in and get their chemotherapy? What is it you're telling? What's the information that you want to get across? The next thing you need to think about is how you support that. Now, this is a pretty dreadful title slide, it has to be said. It's got too many pictures on it, the font changes, the size of the font changes, and the date is wrong. It is a poor slide, but it probably doesn't look that dreadful because we're all used to seeing bloody awful supportive media in many of our talks. Wouldn't it be better to give a slide like this that tells you something about what you're going to receive? It's like the cover art on a book or the trailer on a Netflix show. It gives you a hint about where is this going? What are we talking about? How do I want you to enter this feeling? What is it that's the sensation that's going along with it? And your supportive media can do that. It supports your story in going forwards. And then finally, the third major chunk of it is how to do the delivery. Now, some of you, I think, may have seen this before. This is a sentence in English that can mean 7 different things depending on how it's delivered. I didn't say you stole my money. 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 The same thing, delivered completely differently, giving a different message. How you deliver is also hugely important. And so we need to think about all of those elements when we're doing a presentation. What is the story you're telling? How are you going to support that story? And How are you going to get that message across? That's the sort of trailer and or the entirety of this talk. It's battered down into about 3.5, 4 minutes for the YouTube generation. So for those of you who are addicted to TikTok, you can probably now flick on and go to the next lecture. For those of you who either don't have your phones open or can cope with a slightly longer thing, we're going to go back over those things again in a little bit more detail. Now, I talked about this sort of the story arcs that exist. And whilst they are fictional and they actually work really well for giving sorts of presentations. There's the idea of the rags to riches tale. And sometimes this might be a reasonable thing to do in the setting of children's cancer work. So, for example, do you want to start by talking about the poor, lonely orphan drug that didn't work very well in controlling hypertension? Somebody accidentally dropped it onto some cancer cells and found it started to do some good things, and then started to work on that, got taken on and driven forwards. Do you want to tell a story of a quest, a long-standing program of work that went forwards over the course of 10 or 20 years, taking in different aspects as it went along? It began with a thirst to understand how is Wilms tumor treated across different parts of the world. It got to its first side quest when it got the whole of Europe to do roughly the same thing. It had an enormous great hill to climb or ocean to swim across, when we had the debate between the two sides of the Atlantic, eventually proving that the European approach is far better than the other. And I'm saying that from the safety of the virtual room, and hopefully no Americans in my house. Then we get beyond that to the quests leading into how do we use this treatment in other places in the world that maybe can't support the treatment in the same way? How do we train surgeons? That's a quest all in of itself, as it goes forwards and forwards, leading onwards to the ultimate goal of understanding and curing all children with Wilms tumor across the entire world. Is it a question of voyage and return? Not often something we do in peds oncology, but maybe you need to tell a story about how you went to another unit to learn about what they did and came back again. Wiser, richer, more experienced, more able to see what happens good in your own unit and maybe some of the good stuff that happens in another unit. Are we talking about a comedy here? And comedy and cancer, yeah, go together brilliantly, actually. And you can use comedy and comedic moments to really highlight elements of what you're doing in your talk. A comedy usually centers around some form of misunderstanding or some complexity, and it might be that you're both using the same words to mean different things or whatever it is. You know, it's unlikely that you've got a situation where you've got star-crossed lovers, but if that's the story you're telling in peds oncology, crack on and tell it. Many of our stories may indeed be tragedies, and it is important to tell the tragedies as well as selling the successful quests. We went off down to look to see for a new small molecule that would revolutionize the treatment of relapsed rhabdomyosarcoma, and all we found were multiple side effects and no improvement in people being alive. And then sometimes there's the idea that we went down that negative pathway, but found something there and came out the far side with a greater thrust to go forwards and learn something different, a story of rebirth. Which story are you going to tell your childhood cancer research or your childhood cancer story with? And where does the audience want to feel at the far end of it? Telling stories to an audience in order to get them to give money to your children's cancer charity is different than telling stories to a scientific audience where you want to improve and engage them and want them to think, how might I use this in my work? The story we tell has to change with the audience. And so I'm going to go into a slight different change here and start doing some content. Again, we're about another 4 minutes in, and there's been another slight switch in what I'm doing in the presentation. If you keep going on the same thing all the time, people's brains will switch off. And so keep putting in little twists within it. Maybe if you've got 40 minutes to talk, you should think about that as 10-minute slots and then put 4 separate ideas in as little things spark off as they go through. There are other tricks that will go on, and it's actually a bit weird to give a talk where you're giving a talk about a talk and then explaining the talk while you're talking about it, but please stick with me. When I talk about febrile neutropenia, and I do that an awful lot because I am quite tedious, I do nearly always start with something that explains what is it that's happening. And this is a slide that I used to use an awful lot that shows the sort of spectrum of outcomes from a febrile neutropenic episode, going from the absolutely cold, boring end down to the terrifying end of discussing things with nephrologists and having to debate with anaesthetists on intensive care. That sort of structure of what does this mean gets people's heads in the zone for thinking about what outcomes am I speaking about when I describe medical complications as they go through. So I have that as a sort of an overview of the story. Now, depending on which audience it is, I might then explain more about things or less about things. I might just use this as a shorthand to refocus everybody before we move on, or I might use this as an explainer to go through the basics of it if it's an audience that's not familiar with this. When you're going through these things, sometimes what you want to do is give them a piece of information that's delivered using a technique or a slide or something like that, that is quite outside of their usual understanding. And so for me, in diagnostics, we often want to use the receiver operator curve, the sensitivity specificity plots that show a trade-off between how good a test is at identifying people with disease and how good it is at identifying people without disease. So to do that, rather than leaping into the actual content, I start with an example that sits to the side that is really fairly gross, quite extreme, and you can sort of get your head around quite easily, so that then when you move forwards, you've got those ideas floating in someone's head. So for this, what we've got is sensitivity against specificity on the graph, and we've got a curve, and we've got different blobs. What the diagnosis is of microbiologically proven sinusitis. Microbiologically proven. That means that the grown-ups that took part in these various studies had somebody stuff a needle into their sinus and suck out some snot to see if there were germs in it. The different blobs, and then that's the gold standard, whether they had sinusitis or not. The different blobs are the different ways the radiologists talked about whether this was a positive X-ray, because this is back in the ancient days where we did X-rays for sinusitis, a positive X-ray or a negative X-ray. Now the white ones, the ones with the lowest sensitivity but the greatest specificity, that is, it missed a few that were actually sinusitis, but if it said you had sinusitis, you almost certainly did. It didn't get it wrong. That's what lower sensitivity and greater specificity mean. Those white ones are down at the bottom left end. Those ones are where the radiologist only said it was positive when the sinus was completely full of grot. And that sort of makes sense, doesn't it? If it's completely full of grot, it's highly unlikely to be anything but sinusitis. But you can imagine that some milder cases will be missed by an X-rayologist being that harsh. As you go up and along that curve, you get through to the black ellipses, which show where there's a sinus fluid level or an opacity. And then the grey ellipses at the top, that is the most sensitive. They've diagnosed everybody, but the least specific. They've said a whole bunch of people have sinusitis that don't have sinusitis. Those ones are where, yeah, it was full, or there was a fluid level, or they thought there was a bit of thickening of the sinus, a much weaker positive call. So you can use that to sort of explain things and get people's head around how does this work? How does this system work with something that's sort of understandable and explicable? So that then when you move over to something more interesting, like how C-reactive protein is a really poor differentiating agent when it comes to working out the difference between whether a febrile neutropenic episode is going to have a serious outcome or a real bug found in it, you don't need to really do anything much more because you've already got people's eyes in. On this one, what you can see is that the equivalent of those blobs is taken over by the coloured dots with those crosshairs, and that it is all over the place. There is no consistency here. You could put a few little lines through that, but it's basically a great big mess. You should be seeing a beautiful progression of the rainbow colours from the violets down at the bottom left, right the way up to the reds in the top right, with all of the shades going through a longer line or a longer curve, if it was giving a consistent message. What message that we get here is, who the heck knows what this useful test tells us, apart from it gives us a number we can put down on our lottery cards for the weekend. Now, the other thing I often do is I show a picture of a cat. I show a picture of a cat because for most people, a cat is a calming thing, and it can help you feel chilled, and you can look at the beautiful kitten. For people that have anaphylaxis to cat fur, it doesn't always have that effect, but apart from that, it works quite well. And you use this to calm people down because you're going to show them some maths. And that's the sort of switch that you can sometimes use in order to capture people's attention. Because if you throw maths up on a screen, you often get people to, there's equations. Whereas actually, you don't need to do that. Take people down and then talk about maths. What's even better is not talking about maths at all, and instead talking about shopping. Now, what this is the sort of mathematical basis for mixed treatment comparison or network meta-analysis. And what that means is it looks to see if we put multiple trials together that have compared different things, can we say what we are doing in these trials without having a direct comparison? And so the math says, if we've got trials of comparing A versus B and trials comparing B versus C, then we can somehow understand what is the difference between A and C by sort of putting those two together and doing some subtraction. The way I tend to do this in the UK is by using major supermarkets and seeing within an audience who has shopped in Aldi and who has shopped in Tesco, which is a middle of the range supermarket. And then I look to the very posh people, the professors probably sat over in that corner somewhere, and go, and has anybody shopped in Waitrose, which is a very high-end supermarket where they sell things like scallops and samphire, and baked beans are actually baked individually by hand by the chef for you before they're put into a bag. Maybe it's not quite that good. I've never been in. It's so posh. And you use this to get someone that maybe has shopped in Tesco and Waitrose, someone that's shopped in Aldi and Tesco, and then see which of these is most expensive without a direct comparison between Aldi and Waitrose being necessary. It gives that sort of concept across without being overly scary. Why do you want to do that? Because you want to show a graph like this that shows the output of a network meta-analysis that demonstrates that using single agent tasers within the trials has fewer dead patients than if you put gentamicin or another aminoglycoside in with your tasers when you're using it in your febrile neutropenic empiric antibiotics. Not all of those things are marked. The ones I've chosen to mark are the ones with the most common sorts of antibiotics. You don't have to tell everything. You don't have to say everything. And that becomes really, really obvious if you think about your supportive media when you look at this. The classic way of giving our information across in a sort of scientific-y type presentation is to put bullet points up that tell people what it is you're going to say. This largely gets people to read what's on the slide, not listen to what you're saying. Is there any value in adding the text, the enigmatic smile of the most famous element of the Mona Lisa, onto this picture? Why not just use the picture itself? Or even better, why use the whole picture? Why not focus down and actually show what it is you're interested in? People can look at that, but they'll be listening to what you're saying and be drawn to the enigmatic smile. The same thing applies within delivery of scientific information. This is a fairly standard way of showing a graph that compares the predicted and the actual microbiological infections across a series of data that were collected in an individual patient meta-analysis. It's got maths on the bottom, so it looks like proper science. But why did you need that title there? Did that add anything? I can say that, I can tell you what it is, because I'm going to have to explain this anyway. And indeed, does having the maths at the bottom just put you off? Is it better indeed to have a really straightforward slide like this and explain it around, rather than having that extraneous detail that makes it look maybe sciencey, makes it look what you're expecting, but actually doesn't help getting the clarity of message across? Sometimes having a lot on there is exactly what you want to do. So if you're giving a talk that's all about the different teams involved in a really good pediatric oncology hematology center and just who's involved, you almost want it to be this busy with loads of words all over the place and loads of things going on. And then what you can do is you can bring out the aspect that you want to talk about the most, which is radiotherapy. So you can do it like that. You can do it by removing it and saying, so what happens if the radiotherapy is missing from here? Maybe you can do it by bringing them in by animation. Animation, yeah, very Marmite. Not sure whether Marmite works in a European context. If it doesn't, find a British person in the room and get them to explain Marmite to you, or an Australian and get them to explain Vegemite to you, which is like Marmite, but not quite as good. Animation on slides, maybe, maybe not. Depending on how you're doing it, if you're transferring between Mac and PC, can be a bit iffy. If you're using a Chromebook, can be very iffy. So instead, what you could do is use two separate slides. This slide up with everything on there and the focus down into what you're going to look at as the next section. Depending on what you want to do and how you want to get it across, sometimes it can be really helpful to use that. Sometimes you've got to vary what you do as you go through a talk to wake people up, really. Now, coming back to what we were doing in the first place, introducing it, trying to get people a message of what is it that they're going to receive. How is this going to be done? You might be given something like this to use as your template, as the sort of the outline slide to tell people where you're at and what you're doing. Fairly standard, using the sort of default sizes, maybe a bit of a mess up in putting the font in to put the speaker's name in there. Maybe what you want to do is fiddle with that a bit, because actually the me bit of that is definitely less important, and the message that's coming out there is the presentation skills. Let's put that in and expand that a bit and shrink the person a bit more. Maybe what you want to do instead is really highlight the things that are important about this presentation. This is part of SIOP Europe. This is the brightest minds in pediatric hematology oncology that applied for and won places on this extremely limited course. You are being taught largely by people who are utterly brilliant and amazing around the universe. And then I'm sat here as well. And then that's really key. You want to get that across. You want to say, what is it we're talking about? And then maybe the actual useful thing is some way of contacting that person. So stick up your Twitter handle rather than your extremely long title in order to talk about what you're doing. The same sort of idea can be done when you're talking to non-professional audiences, because you may well be in a situation where you do that, and you can use your supportive media to get different messages across. So it might be that you want to talk to some young people about looking after themselves, and you use something like this. Now, I personally use rainbows a lot in my presentations, and I think it's very important for me to do so. I think a presentation without a rainbow or a unicorn in it is a failed opportunity. Just as a complete sideline, it is worth asking your patients, not at the age of 3 months, but maybe a little bit older, who they love in the world, who they find attractive, how do they see themselves in their gender identity? Because if you can be all of you in front of your doctor and in front of your clinical team, then you can have a much better experience as a patient, and we can fine tune the way we speak with you and the things we explain and the things we talk about going forwards in time, rather than assuming that everybody is cisgendered and everybody is heterosexual. If you're talking to parents, that was an incredible diversion, by the way, and sometimes diversions work really well. If you're talking to parents, you might want to use a picture like this instead. Same words, but giving a different feel. And if you're talking to university age people, maybe you want to do this instead. Now, I've done this, and what this needs you to do is to find the appropriate photo. You can drag it out and put it down so that's the appropriate size for your slide. You then can spend a good hour finding the right font and shade to where to put it on the slide so that it actually presents normally. And sometimes you get to the end of this, and this is exactly how you feel because you've been trying so hard to find the right bits. And then it gets presented and the format's changed and you get really, really annoyed by it. But not today. Scientific talk. Scientific talk about horrendous things. Can you imagine what it's like having bread mold growing inside your lung? Different feel. Same content, different feel. Engage your audience. The reason that lots and lots of dramas have dramatic openings is to get people hooked in. Use those techniques. They do them on Netflix in order to get people viewing. You want to do the same in your talks as well. Just the simple placement of a word. This is anxiety. This is the worry that people get running into an off-treatment scan, or the fear after they've had that scan before they get the result. Placing it there gives you an idea that we're about to have a talk about this, and this is the head, and this is where we're going. Placing it to the side there gives more of a feel that this is the issue that's going on, but less lectury. Or you might put it down at the bottom in order to leap up, because it comes out of nowhere and gives a sense of biting people when they're not expecting something coming through and getting them. Now, you've seen from a lot of my slides that I'm fairly anti-words. Words can be really, really useless, and they can get in the way of the presentation you're giving, but not always. So for instance, we have this thing where we do teaching sessions, and we often have an introduction section that asks people to talk to each other, and particularly in the virtual environment, have a chat, have a bit of an icebreaker when we're going to be doing some small group workshop stuff. So a slide like this can sometimes be helpful, but I still think that a slide like this is better, where you actually just explain what's going on. On the other hand, if you've got an opening slide that's sat there on your virtual thing while you're asking people to come in and sit around, it might be better to use a slide that has the ground rules on it and explains, in this virtual session, this is the sort of things that we will be expecting from you, and this is how we're going to run it. So that you don't need to go through it. It's sort of reminding people, because there is variation in what people do, reminding people of how it's going to be. But even a slide like that can be improved. You can make that a bit bigger. You can actually use a consistent formatting. You can put things in where you really want to take things out in bold and make sure that the ends are all lined up appropriately. So you can get typography to look better. Now, what I'm going to do is whip you through a presentation using some of those techniques of different ways of delivering, different ways of putting information across for a slightly different audience. And so what I'm going to do is give you a talk about teenage and young adults and delivered to that sort of market. So it's that sort of target audience that I would like you to put your heads into. When can I go home is a fairly common question asked by teenagers, young adults, when they turn up with febrile neutropenia and they want to get out the door. They've been persuaded to turn up. They know that they might have a life-threatening infection, but more importantly, there is a gig at the Corn Exchange in 2 nights' time. Can I get out of this place now because I'm really fine? Well, you might be, but febrile neutropenia when you come through my door is like white light. We know that it's going to be a mixture of those with red light, with really serious ICU stuff, and those at the blue and violet end of the spectrum, where stuff is really just a cold, or it was just your mum got overly stressed and she read the thermometer wrong. We know that there's that whole mixture going on. So how can we separate it out? How can we understand which patients turn up and can go home again quickly and which of them can't? Well, what's the thing that sits underneath febrile neutropenia? You know as well as I do that the underlying diagnosis leads to different sorts of chemotherapy. You know, many of you will have had in this room a central venous line, a Hickman or a portacath, and that can be a place that germs can get in. The chemotherapy can give you mucositis, that really horrible sore mouth that you may have seen or experienced yourself. It can squash your bone marrow, and it can also change how well your own immune system works in the other bits as well. Everybody's got germs on them. They're the host flora. They're the things that have friendly bacteria and unfriendly bacteria. And with all of those things together, some of those might jump in and get into your body. The body then comes on and might lead to an actual infection, not just the germ going, no, but actually causing a problem. And that's where not having that immunity to crush it down runs into problems. It might lead to that bad stuff, intensive care and possibly death. And your body does a whole host of sciencey things in order to try to stop it happening. Within that complexity and that mess, how do we know who's going to go down that adverse line and who isn't? Well, we have seen the complexity goes on and on and on. We have seen that people have tried to differentiate this from time immemorial, well, actually the 1980s, to try and work out who is poorly and who isn't. But the studies have largely been done in children, very, very few in young people, and loads of them in grown-ups. The young people actually didn't even have studies on their own. They were bunged in with the children or stuck into the adults. So how can we tell about people in that group? Well, what we did is we got together with a load of our friends and pulled together all of the data sets from many, many children's and adult stuff at the level of each individual patient. And that meant that we had a load of young people that we could then create a pretend study just looking at teenagers and young adults. And then we did some really complicated maths. Now, it had a lot of crunching in and it had lots of things coming through, but did we get somewhere that worked? Well, sort of. In children, we know that about 1 in 5 of them, when they turn up, will have a bad outcome in febrile neutropenia. 4 out of 5 won't. Our best rule at the time could split people into those that were at high risk of problems, a third or so, and those that are low risk of problems, under 10% or so. That same rule in teenagers didn't work quite as well. It was better in a sense of diagnosing those that were at the high risk. 40% of them ran into problems, but the low risk group were only just a little bit less likely to have problems than they were when they came through the door. And when they came through the door, we were worried about them. So we can't use that rule. We can't use it effectively to tell you when you can go home. And so what we really need to do is have a conversation. Not right now when you've turned up because it's too risky. Maybe tomorrow, maybe the day after. How are you? How has it gone? What have we got saying about it? When can I go home is a decision that we have to take together. Now, that's an example that uses a story that seems to be going one way down a quest or a success, but actually ends up being tragic. It uses a variety of different techniques in terms of delivering it and sharing the information using minimal by way of actual numbers and actual words on the screen, but telling the story in different ways. There's something else about presenting, and what you can see is me wearing a fairly standard presenting outfit. Now, what instead if I was giving a talk, but I was giving the talk and I was sat here with my Leeds Rhinos top on and a cap, looking somewhat like Johnny Vegas. and possibly drinking from a beer mug. I can say the same stuff about multivariate analysis and how what you need to do is combine all the stuff together, but it doesn't come across as well. Or maybe it comes across better. I mean, that would be absolutely atrocious, and I just can't do that. That is a crime against humanity. But you can control how you look, certainly when you turn up in person, but you can also control how you look in the virtual world. And many of you will have done this, and you'll know this. You can change your backgrounds. You can put yourself into a more or less professional environment when you do it. And you can sometimes use supportive media that isn't just your slides. So, for example, throughout this talk, you've seen that there's something that looks behind me there on the radiator that's a sort of a brown rectangle. Many of you will, now I've said, go, oh yeah, probably do. Maybe it looks like a pinboard. I don't know what you think about it, but that has been used in one of my talks about creating guidelines for use in paediatric oncology. Because it's all well and good having an absolutely beautiful guideline that is perfect, evidence-based, tells you exactly what to do. But if you hide it, then no one uses it. Just like this really lovely picture of my dog. What's the point in having it facing the wall? What's the point in hiding your guideline? And so, yeah, it's a stunt, but it's also supportive media. It's how can I use things in my environment, not just my slides, in order to get the talk and the message across. And that is sort of an example of a literary technique known as Chekhov's gun. Many of you will know about this. The playwright Anton Chekhov did loads of plays, and he said, if you put a gun on the wall in the first act, by the third act, that gun should have been used to further the plot or to end the plot. So when you see things in a drama, you might see Chekhov's bicycle or Chekhov's ice cream or Chekhov's picture pointing at the wall. You can use that within your talks as well to tie things back in again and potentially to enhance the message, potentially give a message that was subtly going in underneath all along. So, for example, I've been talking a lot about the fact that putting words on slides is often really unhelpful and doesn't get the message across. For example, this is the stuff about people that are forcibly displaced, and I know that that's very much in our minds because of Ukraine. But prior to Ukraine, there was a massive migration of people because they were forced out of Syria through civil war and the most horrendous situation. This information was being shared to try and make people understand what was going on. But it was this image that made an enormous difference in the UK and many places in the world of a young boy who died. You saw that young boy very early on in my presentation. This is the young boy. Sometimes we need to tailor what we do to get a message across. And sometimes we can do that with quiet, and we can do it with pictures, and we can do it with reminding people what's really important. Thank you. I'm very happy to take any questions if there are any. And I now have a Labrador that has come into the room because she heard that I was actually. Tess, say hello. Say hello, Tess. Say hello, hello.
Any questions? Well, to start with, thank you, Bob, for this very inspirational talk. I think we talk so much in daily life. When we work in hospital, we have to exchange information with each other. We make it too complex quite often, as Bob was telling you. So I think I was very strong about that we should have this talk in this meeting, because this is where it starts. We have to exchange and we have to practice, because to be honest, we're all quite poor at presenting. And I think Bob is an excellent presenter. So if you have any questions or you need tips or you want to, yeah, Kathy, please go.
Hi, Bob. Great talk. Where's your cape? I was really glad I spoke before you, because I thought I don't want to follow Bob. But seriously, I do have a question. So we speak in a very international audience, and you and I are lucky English is our mother tongue.
Yeah.
But do you feel there's a place for text on slides to help people who maybe don't understand the English accent of the presenter, or they're American and they speak so fast you can't hear what they're saying?
I think that we should have a way of making American speakers come into our ears at half speed, like we can with podcasts. In a sense, yes, you have to tune what you're doing for the audience. I would prefer that we had better accessibility for many things. So for people on the screen now, you probably don't have auto captioning on for me, but Zoom and Microsoft Teams have now an auto captioning function that can give you live subtitles as you're going through a talk, and they can be switched on to help people access things. You do need to think about your audience, and sometimes having a text there to help people get along can be really important, along with a QR code or a short code or something towards the end that can help people by going off to an appropriate paper or a website or a blog or something that summarizes it. We are, I agree, we're hugely lucky in being English as the first language for me, and able to understand the variety of accents, and I appreciate working in the international sphere is different. I think the other thing that's worth saying about that sort of idea of privilege is that when you are a cisgender white bloke who's getting towards the back end of middle age and given a sense of structural power, you can get away with a lot more than if you're in a very different situation. And I know that I'm talking these things and giving these sort of hints and tips from a position of power, and that it is more difficult to move away from what is expected if you are in a position of less structural power. That shouldn't be the case, but it probably is still at the moment.
Any other questions?
Thank you, Bob. That was a really good talk. Do you have any tips for when we're giving presentations on a topic that we might feel is quite complex, or a piece of work, a big piece of work, but we're asked to give a short presentation? So as few slides as possible, few minutes. Any tips?
Yes. Give the headline. Give the subhead. Stop talking. When you look at a newspaper article, blog site, whatever, we'll leave the clickbaiters out to one side. The headline gives you the key message. What is it that if they had to walk away with one message, you'd want them to get? That's the headline you want to give them. It may not be the title, which you might want to use to attract them in, but you want to give the headline, what is the one key message? And then your subhead explains that. What is it that you'd like them to know about the nuance? And then if you get the chance, 50 words of how and why you get there. And after you've done that for a few of your papers, you then start to think, what was the point in writing the other 3,400 words? Because I've just said it all in 100. And that's what you've got to do. You've got to, rightly, you've got to kill your darlings. You've got to lose the stuff that's really, really interesting and took you 3.5 weeks. And honestly, you sat by the side of that cell whispering how beautiful it was and how it was lovely, and would it please just divide a little bit more? You lose all of that and you go, put this on it, it died. give that headline message in that setting, because people can always ask you more. But if you're talking at this sort of speed now to get everything through and you've only got 3 slides and you put everything on in 13 point, blah, 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 then you get nothing across. No one will speak to you. No one will ask you any questions. Give them a little and they'll come back asking for more.
I'm sorry, I have another question. I know it's very important to make the audience laugh, or to make the audience have some fear or something, some kind of feelings, because I think it's better for us to remember. There's a link between remembering and feelings. And is it also like important to make the audience doubt? Because I think I have a question about the Mona Lisa you showed. Is it the real Mona Lisa?
One excellent question. I think I'm going to cop out and say it depends, because it really does. It depends on the people you're speaking to. It depends on what you want them to feel. It might be that you start your whole talk with a question. Is there any point in trying to repurpose drugs? Because frankly, we've been trying it for 10 years and we've come out with maybe 1 or 2 things that even aren't that useful. Shouldn't we just be putting effort into something else instead? And then move on to say how new ways of assessing repurposing actually might make a difference. And we are seeing things coming through, despite what we found in the past. So maybe doubt can be a useful thing again, but it really does depend on what story you're trying to tell and how you want people to leave, in a sense.
I think this, Carmelo has one last question.
Thank you very much. It's a great talk. You will forgive me, but I wanted to pick from your talk for this audience a message that you have to be prepared always, not only for talking to an audience of medical doctors, but also when you go to the parents. You have to be prepared. You have to know what to say. You have to prepare yourself. You have to know also what kind of language, because they cannot be the mother language as you are, or they can have different skills in understanding. So the message for the audience from my side, from this excellent talk, beyond the presentation to scientific people, is be prepared and take your time.
Thank you. Wholeheartedly agree.
Thank you, Carmelo. I wanted to introduce the First Time magazine article. And Bob, you're very welcome to listen if you'd like to.
I really would love to, but I'm afraid I've got to head off to another thing that I'm now a little bit late for.
Okay, enjoy.
Thank you. Bye-bye. Thank you, everyone.
Bye-bye. So
I hope there's not so much pressure now in the next 3 presentations.
You were